So we'll start with the joint cell arthritis. So the joint cell is named because there are joint cells on histopathology. So it's easy to remember if they ask what type of cells are seen in histopathology. So one type of cell which you see are joint cells. So it's also called temporal arthritis because superficial temporal artery is commonly involved in this condition. So what is what is the definition of this condition? It's chronic inflammatory disorder, usually with granulomatous inflammation that mainly affects large to medium size vessels in head. So it's chronic inflammatory disorder with granuloma formation that affects vessels of head. So what are vessels in head? Vessels in head are head and neck vertebral artery, ophthalmic artery, and also aorta. Aorta is not in head, but it says usually it affects in that part, but it also affects our aorta. So it's medium to large to medium size vessels. So what is the pathogenesis? So the vessel wall, it's presumed that vessel wall has an antigen and there is T cell mediated immune response to that antigen is unknown antigen, unidentified antigen. And T cell response happens and then the T cell response makes formation of granuloma. So now granuloma is formed granuloma is formed when there is antigen which immune system cannot get rid of, like tuberculosis or any foreign body. The immune system will try. There'll be macrophages, and they cannot eradicate the antigen, so they form a granuloma. These inside are macrophages, and outside we get these lymphocytes. So this is granuloma. So this is granulomatous inflammation. These are macrophages, and then these are lymphocytes, and then some of the macrophages they fuse, their cell wall fuse, and they form large cells which have more than one nucleus, and these are called joint cells. So the histopathological features will be macrophages, lymphocytes, and joint cells, and then some changes in vessel wall. But these are the general features of granuloma. So majority of lesions are granulomatous in joint cell arthritis in inner part of media. So we know the vessel wall has intima, and then it has media. The media consists of smooth muscle cells, and then there is adventitia outside. So intima is endothelium, and this is inner media, this is outer media. So the inflammation starts here, it progresses to granuloma. Granuloma then destroys the smooth muscle cells, and this leads to thinning of media, and it also leads to disruption of internal elastic lamina, which is at the junction of intima and media. So we'll discuss the histopathological features, because if only we are given histopathological feature, we should be able to identify this condition, or we should be able to describe histopathology if we are asked about. So what are clinical features? These can be non-specific features of chronic inflammation like fatigue, fever, and weight loss. Fatigue, fever, and weight loss. And then these are the specific symptoms: headache, pain, and tenderness along temporal artery in temple, jaw claudication, facial pain, These are the symptoms when somebody has headache and points to temporal region and there is a tender spot, then we should think of this diagnosis. But the most important is that this arthritis can involve ophthalmic artery and leads to thrombosis of ophthalmic artery that can cause diplopia and complete loss of vision, and that can progress over short period of time. So we should know about this diagnosis. If somebody has headache and tenderness in temple and his vision starts deteriorating, then we should think of this condition. Then we do not go for a lot of tests. We just start the treatment, and treatment, as it is a chronic inflammatory condition, so treatment is high dose steroids. Oral steroids, uh, if uh, with if there is other features like facial pain or pain and tenderness in temporal artery, but if vision is involved, then we start methylprednisolone. So this is the question: what you will do if there is change in vision? I will start him in high dose IV steroids, glucocorticoids like methylprednisolone. Will not go for test like confirmation of test because this can progress suddenly and person can lose vision. So histopathology, other thing important to know is that the uh, changes are typically like if this is artery, we may find a granulomatous lesion here, then we may not find it for quite a few centimeters, then we find another lesion here, then another lesion. So if we take biopsy from here to here, the biopsy will be normal. So it's minimum of 1 centimeter length temporal arc biopsy we need to take, but usually it's 2.5 centimeter. So we need to remember this point that biopsy needs to be minimum length of 1 centimeter, but usually around 2 to 2.5, 3 centimeter. And even then, a negative biopsy does not exclude diagnosis. If we take biopsy from here, it may not be positive. And then also, sometimes the inflammation is not granulomatous. So in that situation, there will be non-specific inflammation. So we need to understand this, that one, it is patchy, then it's usually granulomatous inflammation with infiltration of T cell, macrophages, multinucleate giant cells. Then there is loss of vascular smooth muscle cells that leads to thinning of media, and there is fragmentation of internal elastic lamina, and there is thickening of intima. Intima will be thickened and media will be thinned, which is smooth muscle cells, and then if when healing phase, this can cause scarring. This will cause intimal thickening, cause narrowing of blood vessel, and then there it can also result in formation of thrombus and distal ischemia. Because there is nodular thickening, the granulomas cause thickening, and sometimes thrombosis that reduce vessel diameter and lead to distal ischemia. So this is diagram. If we are given this diagram, we should think of like this is lumen. We can see white blood cells in lumen. We can see this whole is intima. Then this is smooth muscle cell. This pink eosine uh, circular cells are smooth muscle cells. So this is media. But in most important thing there is significant thickening of intima. Intima is usually one layer, but it appears a proliferation and quite uh, uh, increased diameter of intima. Then here we can see a uh, multinucleate giant cells. We can see there are many nuclei in this giant cell. There is only one giant cell. If we can identify this will be very good, but it's not necessary. And this is the thickened intima giant cells. Giant cells and granuloma are absent in 25% of cases. And this diagram is elastica stain about elastic tissue. This is internal elastic lamina. This is a junction of intima and media. This is internal elastic lamina. So we saw the loss of internal elastic lamina. So we can see there's no internal elastic lamina on this side. And there is granuloma at the junction of intima, and media. So this granulomation tissue, this whole looks like granuloma, and it leads to destruction of thinning of media. We can see media here is quite thick, but here almost no media or very thin media. This one. So loss of internal elastic lamina and thickening of intima, thinning of media, and granulomatous inflammation, multinuclear giant cells. This depends on stain. This is HE stain and this is elastica stain. So we probably should be able to remember the pathological findings now. So how we do diagnosis? The simple test. What is simple test? ESR is significantly raised in this condition. So simple test is do ESR, it will be very high. And then you start treatment. Diagnosis is confirmed by temporal artery biopsy, however, due to patchy involvement of vessels. Normal biopsy does not exclude diagnosis. What is treatment? High dose steroids, intravenous methylprednisolone when involvement of vision, and treatment needs to be started before confirmation of diagnosis to prevent blindness. We can start treatment even with the even for when there is no involvement of vision. But in that case, we can start oral steroids. But there is when vision is involved, we start methylprednisolone, and it gives very good response clinically. So the things to know is it can cause blindness. Then no need to confirm diagnosis before important points are and you can start steroids, and simple test is doing ESR. So now you start a person on glucocorticoids, and he develops fracture neck of femur, or anybody on he develops neck of femur fracture. So how steroids result in fracture neck of femur or osteoporosis? So the bone health depends on osteoblasts, and osteoclasts, and calcium level. And there are several hormones uh, like parathyroid hormone, but they affect through osteoblast and osteoclasts, and there are also estrogen and testosterone, sex hormones. So if anything which inhibits osteoblast, mean bone will not be formed. Anything which increase osteoclast will result in osteoporosis. So the steroids does both. They inhibit osteoblast and they increase the osteoclast. They decrease the absorption of calcium from gut, and they decrease the absorption of calcium from kidney. So they promote calcium loss as well through kidney. They may also cause hyperparathyroidism, and they inhibit sex hormones, and that also predispose to osteoporosis. So there are several mechanisms. So this can result in osteoporosis and can result in fracture neck of femur. So this is one of the reasons we do not want to give a person long-term steroids. So now we have seen that this fracture neck of femur happened due to osteoporosis. So what is the no, we have further questions about osteoporosis. What is osteoporosis? Define osteoporosis. What is osteoporosis? It is a progressive bone disease. It is a progressive bone disease, or it is a metabolic bone disease. And it's characterized by what? Reduced bone mass, microarchitecture deterioration, and increased bone uh, fragility and risk of fractures. So it's basically reduced bone mass. It's reduced bone mass with increased risk of fractures. That's enough. But if you can add with microarchitectural deterioration, then it completes the definition. So it's a progressive bone disease that results in decrease in bone mass and that increase the risk of fractures. So what are the mechanism of osteoporosis? There's a primary osteoporosis and secondary osteoporosis. Primary osteoporosis is when there is no definitive additional cause, but in uh, like it's old age condition, it's postmenopausal condition, and reduced physical activity. Uh, Again, it affects osteoblasts or osteoclasts. So in senile osteoporosis, there is reduced proliferation of osteoblasts and biosynthesis potential of osteoblasts. So it affects osteoblasts. Estrogen, when it's present, it inhibits apoptosis of osteoblasts and promotes apoptosis of osteoclasts. So increase osteoblasts and because it inhibits apoptosis of osteoblasts and decrease osteoclasts. So it means more bone forming and less bone degradation. But when there is deficiency of estrogen, then opposite thing happen. There will be less osteoblasts and increase osteoclasts, and that's the in thinning of bone. And reduced physical activity is uh, there are factors when there is reduced physical activity, like lying in bed or putting a arm, forearm, or leg in a POP cast that results in high bone resorption, and that also leads to picture of osteoporosis. And then is the calcium and vitamin D nutrition status. So what are mechanism? This is the mechanism. These are the detailed mechanism in senile osteoporosis, postmenopausal, and the overall osteoporosis is the same. Increase bone turnover or decrease bone formation. This means increase osteoclasts. This means decrease activity of osteoblasts. And then is the low peak bone mass. If somebody has low peak bone mass in younger age, they are more prone and will develop, will progress rapidly. So how is this diagnosed? This is just for a knowledge question. We measure the bone mineral density with dual energy X-ray absorptiometry called DEXA scan of spine and hips. And if it is more than 2 standard deviation, then we say this person has osteoporosis. So causes of primary osteoporosis we have discussed. Secondary osteoporosis has many causes. This depends on calcium and also vitamin D, but calcium is anything which impairs the absorption of calcium, and also vitamin D can cause this, like malabsorption, malnutrition, scurvy. Endocrine disorders, Cushing syndrome, hyperparathyroidism will obviously cause because it increases osteoclast. Cushing disease again due to steroids, hyperthyroidism, gonadulin deficiency. So we know we have discussed this before, so we can make things like this. Endocrine, drug-induced. What is in drug-induced? Again, corticosteroids, immunosuppressant drugs, alcohol, as much as we can, if we know at least corticosteroids are important cause. An inflammatory disorder, any inflammatory disorder also affects osteoblast, osteoclast, hemostasis, like rheumatoid arthritis, tuberculosis, rheumatoid arthritis. You also get decreased activity due to arthritis, so that's additional factor, but inflammation itself caused. And then malignant disease, multiple myeloma is important. Then others is CKD is important, immobilization, osteogenesis imperfecta, smoking. Smoking is also an important cause. We should know smoking cause osteoporosis, can come across quite often. So these are the causes. As much as we know, we should know difference in primary and secondary osteoporosis, and causes like nutritional, few nutritional causes, and then endocrine and drug induced. Or if we can't tell them, divide them in different, we just tell malabsorption, malnutrition, Cushing disease, hyperparathyroidism, corticosteroids, smoking, CKD. I mean, that's also a possible way to tell. So no pathological fracture. So osteoporosis is one of the cause which results in pathological fracture. Pathological fracture is when fracture of bone fractures with minimal trauma, in, and with that amount of trauma, normal bone will not fracture. But if we get unexpected fracture with minimal trauma, then we think there is a problem with bone structure. So there is the reason for that are generalized bone disease, local bone disease, and primary bone tumors and metastatic. So if we divide like this, we can remember many things. Like metastatic tumor, we should know which tumor metastasized to bone, breast, lungs. These are two main. Thyroid, it's not that commonly seen, but it's one of the reason. Prostate, breast, lungs, prostate, kidney, thyroid, any of these metastases can end up suddenly in uh, pathological fracture. Then primary bone tumor is osteosarcoma, Ewing's tumor, and chondrosarcoma. Any bone tumor actually, but osteosarcoma, Ewing tumor. Local bone disease, bone cyst, chronic osteomyelitis, chondroma, which is the of tumor of cartilages. And generalized bone disease, osteoporosis is here, multiple myeloma is here, Paget disease, which is again increased turnover of bone, and osteoblast, osteoclast imbalance, and osteogenesis imperfecta. But we should, as a surgical exam, we should think of osteoporosis, multiple myeloma, and maybe Paget's disease. So this was about steroids and osteoporosis. Now we go into section of MEN syndromes, multiple endocrine neoplasia syndrome. So there are in this exam, these are the still previous pattern MEN1 and MEN2. In MEN2, we have 2A and 2B. Sometimes they say MEN2B as MEN3 as well. And there is new syndrome, MEN4 as well. But this not for exam. The exam they just ask these. Here they just these are the 2A and 2B. Even not MEN3 is the what we need to understand. So these are the syndrome, as name say, multiple endocrine neoplasia that involve different endocrine organs. But what organs? There are not plenty. Pituitary, pancreas, parathyroid, thyroid, and adrenals. These are the main involved uh, uh, glands involved. But in pituitary, there may be 5, 6 different type of tumors, and pancreas also there may be different type of tumors. And but generally we should know it. For this exam, if we even know that MEN1 has involved pituitary, pancreas, and parathyroid, that's enough. But if we know more, that's good as well. So the way to remember is ME1 has 3 P's. 1 P is pituitary, but in pituitary it can be adenoma, secreting growth hormone. The most common is one that secretes prolactin, growth hormone, and others as well, or it can be non-functional. And in pancreas, we can have insulinoma, we can have glucagonoma, we can have VIPoma. So in pancreas, there are quite a few. I mean, there can be functional and non-functioning, but I mean, overall, generally we see pituitary adenoma, pancreas adenoma, and parathyroid. And parathyroid is mostly hyperplasia. Sometimes it's adenoma in this condition. So in MEN1, we can see that we have 3 P's: pituitary, pancreas, and parathyroid. So what causes MEN syndrome? all these syndromes are autosomal dominant, so we do not need to remember which one is dominant and which one is recessive. So all these three syndrome are autosomal dominant. In MEN1 gene, MEN1 has MEN1 gene defective, and this uh, produce menin. This gene encodes a protein called menin. So what's function of menin? Menin is a tumor suppressor gene which prevents formation of which prevents the excessive growth. So when this there is defective menin, there's no menin, then it results in formation of tumors in different endocrine glands. So ME1 gene encodes MEN1 gene, which is tumor suppressive. That's enough. Uh, and This is MEN1. We'll discuss more later on. MEN2A is two P's and one M, which is 2P. One is parathyroid and one is pheochromocytoma. There is no pancreas and pituitary here. So parathyroid, pheochromocytoma, and medullary carcinoma of thyroid. Medullary carcinoma of thyroid is prominent feature of both 2A and 2B. This is very important because this is the very high risk condition, and this happens almost 95 to 100% of patients, or almost all patients, and this happens at very young age in MEN2B. So this one, MEN2, this one we need to remember that MEN2B is medullary thyroid cancer is a serious condition involving both these. And if somebody has medullary thyroid carcinoma, we should also think like he may have pheochromocytoma. And so 2A is parathyroid and medullary thyroid carcinoma and pheochromocytoma. But in this, parathyroid is not prominent. It happens only few percentage of people. But in MEN1, parathyroid adenoma happens in a lot of 80% majority of patients, most of patients. So although it's not prominent. Prominent here is medullary thyroid carcinoma, and they may have pheochromocytoma and may have parathyroid. Parathyroid is less important, but that's part of this. And in this MEN2B, there is no pheochromocytoma. It is there is pheochromocytoma, and because this is MEN2, there is one P and two M's. There is pheochromocytoma 1P, and again, the most important is the medullary thyroid cancer. And then the other M is mucosal neuroma and morphinoid habitus. So mucosal neuromas are lesions in oral cavity in mucous membrane, and morphinoid habits is long stature, long limb bones. So it's actually three M's probably. This is one M, this is one M, and this is one M, but says one P and two M's. So this is what is called it's RET gene, RET gene. It's proto-oncogene. Like this is tumor suppressor gene, and this is proto-oncogene. Tumor suppressor genes are genes which suppress formation of tumor, and when they are abnormal, it results in formation of tumor. Proto-oncogenes are that stimulate the growth of a tissue or epithelium. They are they are usually they stimulate the growth. So, but they are kept only they stimulate the growth when there is a signal. But when these genes are defective, uh, then they cannot they lose their capacity to to control this growth, and they just keep uh, growing even when there is no growth signal, like there is no tyrosine kinase, and they then even If there no tyrosine kinase, then even I mean, there's no signal, they keep result in excessive cell growth. So this is important. Proto-oncogene and tumor suppressor gene. We'll discuss later on, but in this, the MEN2 is caused by red gene, and it results in proto-oncogenes that is receptor for tyrosine kinase. So this proto-oncogene is a receptor for tyrosine tyrosine kinase. This is a receptor. This is red gene encodes this receptor. So this receptor only works when there is a signal. But when this and then it signals downstream and nucleus and division. So if this is defective, the defective gene, if even there is no signal, it will send downward signals and results in growth and proliferation and tumors and cancers. This again same picture, MEN1, same thing described here. So this is, we have discussed, we can see parathyroid hyperplasia or adenoma in 80 to 95%. Mostly it is hyperplasia. Sometimes it's adenoma, and its first presentation in 94% of cases. So they present with parathyroid hypercalcemia, parathyroid hyperplasia, and then ultimately you find that they have, I mean, if they may end up having later on other symptoms of this syndrome, but at first they will present like this. Then they may have pancreatic endocrine tumors and pituitary adenomas and some other conditions, but these are less important. We just concentrate on these three. So pancreas endocrine tumors are often functional. They secrete hormones, gastrinoma, which causes Zollinger-Ellison syndrome, insulinoma, which causes hypoglycemia, the second most common, and VIPoma, which causes VIP secretion, and it leads to diarrhea and glucagon, diabetes, and skin lesion. So these are the functional tumors of the pancreas, and then pituitary also around 50% of are the functional tumors. Most common is prolactinoma. 60% we know what are the signs and symptoms of prolactinoma in males and females. And then growth hormone and ACTH, which can lead to Cushing syndrome and also non-functional. Most pituitary adenoma are microadenoma, but we do not need to, this will be extra point if we tell them, or PTH, primary hyperthyroidism, which involves four-gland hyperplasia. So diagnosis is by PTH, we do, which hormones can increase like PTH, prolactin, pancreatic polypeptide, gastrin, and then we do imaging, CT and MRI, and genetic testing if needed. If we feel like there is more than one thing positive here, then we do. Then we do it. Then we also do for first degree relative. But this is not just the scope. We can just mention we'll do genetic testing, just for understanding. So this MEN2A is medullary thyroid carcinoma. Almost all patients by usually during the first 2 decades, but in this case, it is 90 to 100%. It's multifocal and more aggressive and happen in very young age. So they do prophylactic thyroidectomy in MEN2B condition when we have it. We know the condition. And pheochromocytoma in 50% of patients. So when these patients, anybody with medullary thyroid carcinoma, we should think of assessing him for pheochromocytoma before operation, because if we just proceed with the operation, he may end up in crisis due to excessive catecholamines and may end up in serious complication. So when there is medullary thyroid carcinoma, we check for a screen for pheochromocytoma. This also can have pheochromocytoma. So hyperparathyroidism, 10 to 20% of patients, and majority of patients are asymptomatic, unlike this side, because they are there's mild hypercalcemia. in mucosal ganglioneuroma of lips, tongue, and GAT. So prophylactic thyroidectomy in first year of life in MEN2B or MEN3. So we see that in MEN2, it's the medullary thyroid carcinoma, which is important condition. So first we discuss insulinoma, which is tumor of beta cells of islets of Langerhans. We know it's associated with MEN1A, with the pancreatic functional tumor. And it has, how we diagnose it, we see there is high insulin to glucose ratio. Like it means when glucose is low, the insulin should be low. But in this condition, glucose will be low, but insulin will be high. So this is the ratio is opposite, high ratio, more insulin when more than it should be according to blood glucose levels. There's a high level of C-peptide. So insulin is secreted as insulin and C-peptide. So after the insulin, it's cleaved and insulin becomes separate and C-peptide is also present in blood. So if it's endogenous insulin, will have C-peptide as well. But if it's exogenous, will not have any C-peptides. So person will have a recurrent episode of hypoglycemia, and there'll be a poor response to, there'll be excessive insulin after if we give him insulin, if we glucose tolerance test. Causes of parathyroid hyperplasia are MEN syndromes and renal failure. So parathyroid hyperplasia occurs in MEN syndromes, we discussed, and renal failure, it can happen, one of the two of the causes of parathyroid hyperplasia can happen sporadic, but it happen in most patients in MEN1. Renal failure patients are also predisposed to this. So what are the features of microscopic features of parathyroid hyperplasia? So parathyroid gland consists of chief cells. Chief cells are small cells, round to polygonal, and they are present. Then usually in gland there is fat cells, there's stroma, and then there are oxyphil cells. Oxyphil cells are larger than chief cells and they are pink. So this is normal parathyroid. These chief cells are more frequent. They form glands. So they are chief cells are more frequent. These are the cells which secrete parathyroid hormone, and then there are oxyphil cells and fat cells, and then there is stroma. So this is how it looks like. So what happens in hyperplasia is it's usually due to the proliferation of chief cells. So you get chief cells, excessive chief cells, proliferated chief cells making glands and nodules, and then normal area, and then again this. So this is nodular, uh, uh, usually nodular, but can also be diffuse growth pattern of usually primary. It's due to chief cells, although oxyphil cells are also present, but mainly hyperplasia of chief cells. There will be reduced intracellular fat, which we discuss here, and there will be absence of peripheral rim of normal parathyroid, we'll discuss later on. So water clear cell is a variant in which the hyperplasia is due to water clear cells, and these cells are large with clear nucleus. Like these cells have basophilic nucleus. Chief cells have basophilic nucleus, basophilic cytoplasm, which we'll see later on. So now we come to this genes that cause cancer. So oncogenes, uh, tumor suppressor genes, and DNA repair genes. So oncogenes are the genes which promote growth And when they promote growth, but they promote growth when there are adequate signals for growth. But if oncogenes, called proto-oncogenes, when they are mutated, you get excessive growth even when there is no signals from outside. So which are these genes? This is HER2 gene. HER2 is a epidermal growth factor receptor gene. Then there is KRAS gene, there's Mike gene. There are several examples, but these are the genes which promote growth, but they promote growth only when there are adequate signal, but that are called proto-oncogenes. But when these get mutated, then these are called oncogenes. So oncogenes are the genes which then promote growth even when they are autonomous. They promote growth even there is no growth signal. So when oncogenes, all the genes we know have two copies. For oncogenes, in if even only one copy is abnormal, they start they end up promoting cancer. But tumor suppressor gene, there are two copies, and these are usually recessive genes. So this they have to have both copies deleted before they can make cancer. So this is called two-hit theory. In tumor suppressor gene, they are usually autosomal recessive, and both copies needs to be abnormal before they can cause cancer. So what happens is sometimes the one copy is inheritedly abnormal, like one copy is inheritedly abnormal, and then uh, second copy is mutated later on as a sporadic or random. So one copy is defective inherited and then both are abnormal, then it results in formation of genes. So it's very important. Tumor suppressor gene, both copy needs to be defective, and this is called two-hit theory. Like retinoblastoma gene, at birth they have one inherited copy, then they get other mutation, and then they get Wilms tumor. When then they get retinoblastoma at very young age. So in sporadic cases, both mutations occur randomly over time. There's no inherited uh, this no inherited defect. So what are the tumor suppressor genes? P53 retinoblastoma, uh, adenomatous polyposis coli APC gene, and there are some DNA repair gene. There are these repair DNA like BRCA1, breast cancer 1, breast cancer 2, MSH2, MLH1, MSH6. These are the genes that repair DNA, and when these are defected, then you get they predispose to cancer. So oncogenes, tumor suppressor genes, and DNA repair genes. So what is telomeres? So each chromosome at the end has nucleotides, a series of nucleotides that is called telomere. So telomere is a series of nucleotide at the end of chromosome. What's its function? Its function is because the chromosome starts from here. It just protects this chromosome from degradation here or binding to other chromosome. So these are repetitive nucleotide sequence at the end of chromosome that prevents its degradation, fusion, and other chromosome damage. So no question is which genes are mutated in insulinoma. So there are the number of genes. MEN1 gene we know is we already discussed. It happens in MEN1 syndrome. And this is P10 and TSC2 genes. So P10 and TSC2 genes, they don't regulate P13K and mTOR pathway. So P13 and mTOR pathway, they uh, maintain the integrity of beta cells of pancreas. So when uh, these two genes are abnormal because these are two different genes, and they maintain integrity of beta cells through P13K and mTOR pathway. So when these genes are defective, they cannot maintain the proliferation. The proliferation is affected of B cells, and it results into overgrowth of B cells, causing insulinoma. So one is MEN gene, then is P10 and TSC2. TSC2 is actually tuberous sclerosis complex gene. Is it a gene associated with tuberous sclerosis? So P10 and TSC2, they they express the P13K and mTOR pathway. Then is DAX and ATRX gene. DXX gene is this the name, but we do not need to remember that associated protein 6. These two genes are associated with chromatin modeling, remodeling. Chromosome, is two copies, and it keeps going from one copy to two copies. Uh, it goes to chromatin remodeling for expression of genes. So there's also a delicate process, and if there is any defect in this, then it also predisposed to insulinoma. So MEN gene, P10, TSC2, DXX, and ATRX gene, KRAS in few cases, but it's not important if you know these 4 or 5 genes. So MEN2, we discussed, it has medullary thyroid cancer, and medullary thyroid cancer is originates from C cells called parafollicular cells or C cells. These are neurocrest cells, and these secrete calcitonin. So calcitonin is calcitonin is the secreted from cells which have opposite effects than parathyroid hormone. It promotes osteoblasts, and it inhibits osteoclast. So uh, calcitonin. So as this medullary cancer is cancer of C cells, when these cells are excessive in number, they result in excessive calcitonin. So we can measure that excessive calcitonin, and it works as a tumor marker for medullary thyroid carcinoma. Elevated calcitonin level and also calcitonin can be detected in immunohistochemistry in medullary thyroid carcinoma. So we have a thyroid tumor, we do immunohistochemistry against calcitonin, and we find that this is so calcitonin can be detected by immunohistochemistry. So histopathological features of medullary thyroid carcinoma is cancer is will can identify calcitonin in tumor cells, and with and calcitonin can form amyloid deposits. So we can detect amyloid deposits if a histopathology of a cancer has amyloid deposits in thyroid cancer, then that is medullary carcinoma, not the differential thyroid cancer that has follicular uh, follicular type. And second is calcitonin, identification of calcitonin. So detected by immunohistochemistry. What's immunohistochemistry? We'll discuss it later on. So if a histopathology is telling person has thyroidectomy and he had amyloid deposits and we detected calcitonin, then it is a medullary thyroid carcinoma. Then when medullary thyroid carcinoma comes, we should think of MEN2 gene and what other genetic conditions cause it. So MEN2A and MEN2B, they have red genes. We know they have red genes, but if there is a sporadic medullary carcinoma also have same gene, a red gene, but this red gene is not inherited. It's just sporadic mutation. And a familial medullary thyroid carcinoma is another variety. It also has red gene mutation, but it only causes medullary thyroid carcinoma, is not associated with other MEN syndromes. 30% of medullary carcinoma are associated with MEN, these three hereditary syndromes. So what is immunohistochemistry? Immunohistochemistry is a laboratory technique but by which we identify antigen in tissues or cells with the help of antibodies to that particular antigen. So we identify antigens in tissues or cells, and how we identify these antigens in tissue and cells with the help of antibodies. So what are steps? First step is tissue is adequately fixed with formalin or cryopreserved in case of frozen section. We have this tissue and this tissue has cells. Suppose we want to identify this antigen. So this antigen we want to identify, and what we do is first we have a primary antibody against it. So we have primary antibody which comes and attached to this. So this means this antibody is attached. So if there is another cell which has same antigen, then antibody will attach here. Then we have a second antibody which is against this antibody. So this is secondary antibody. This will attach to this. So this second antibody has a molecule, has certain compounds with the help of which we identify, like if their antigen present or no. So these can be fluorophore or these can be enzymes. So what happens is if this antigen attached to this enzyme, if this is a if this is an enzyme which change is substrate. So after we bind first antibody, then we uh, uh, put second antibody, then we put that chemical. Like suppose we put a chemical that has a yellow color, and this yellow color change to orange color. That orange color will be changed by this enzyme which is linked to secondary antibody. So this color will only change when antibody is attached and present on tissue. So then we analyze this tissue under microscope, and what we see is fluorescence. What we see will be the color change only. So when color change is present in tissues, it means there is antigen here. That's why that antigen attached to these two antibodies, and that resulted in this color change. So this technique is called immunohistochemistry. So what is this? Identification of antigen with the help of antibody to that antigen in tissues. So what is this reaction? So this reaction is simple reaction, that is covalent, non-covalent binding reaction or affinity based reaction. So this is non-covalent binding. Antigen has this antigen, antibody has affinity to this antigen. So this is affinity binding reaction or non-covalent. There is no covalent binding, and then the second antibody binds to it, and then we detect it. So we should be able to tell what is reaction. It's non-covalent binding, affinity binding of antigen to antibody. Then a second antibody binds, and that has enzyme or fluorophore, and that fluorophore that results in change in color at the site where antigen antibody reaction is happening. We'll stop here, and next time we'll discuss pure chromosome.